Scientifically speaking, we're sharing the view. From labs to clinics, breakthrough shining through. With minds that inspire and stories to unfold. Scientifically speaking, the future's being told.
Welcome to another episode of Scientifically Speaking with Christine on Oz Arab Media. Today, we're focusing on your eyes, arguably our most precious sense, and how recent advances in ophthalmology are changing what it means to protect, restore, and optimize vision. From children's eye health to cutting-edge glaucoma and cataract care, there is a lot shifting beneath the surface of standard eye checks. Joining us today is Dr. Elias Kehdi, a Sydney-based eye surgeon whose work spans pediatric glaucoma, cataracts, squint, and general ophthalmology. He trained at Sydney Eye Hospital and then completed fellowships in the UK at Manchester Royal Eye Hospital, specialising especially in paediatric glaucoma. So Dr. Kehdi, welcome to the show.
Thank you for having me, Christine. It's a pleasure to be here. I know we tried to work out a time earlier,
yes.
But we finally made it. I finally made it.
We finally made it. I'm so glad, and that's my life with doctors in general, so it's okay.
My wife would agree.
Amazing. Dr. Kehdi, if you don't mind me, I start straight away. For our listeners who may not know about ophthalmology, can you please briefly explain what is an ophthalmologist, what he does, and how is he different from an optometrist?
Very good question.
Thank you.
In medicine in general, you find in specialty, different specialties, you'll always find a different stream for the surgical side and the medical side of care.
Right.
That is true probably for a big proportion of the different specialties. Ophthalmology is one of these specialties that is different in that an ophthalmologist or an eye doctor, an eye specialist, is actually an eye surgeon and physician at the same time.
Right.
So we treat both medical cases and we do surgical treatment as well, as opposed to something like, for example, a cardiologist is a medical physician versus a cardiothoracic surgeon who does operations on the heart, but they only do surgeries. They don't treat medical conditions of the heart.
Right.
Ophthalmology is one of the very few specialties where it does both, and that's one of the reasons I did it. This is why I like to do it. I like to be more involved. How does it differ from optometry? I think, look, the best way to sort of distinguish the two, you can think of an optometrist as a general practitioner for eyes.
Okay.
They are well qualified in assessing both vision and the health of the eye. They do very well screening for different conditions, and we'll talk about a few of the conditions soon. And they work in close connection with the ophthalmologist to provide full care and complementary care for the patient in terms of the eye health, the vision needs, both for adults and children. So there's a small difference, and it's becoming more and more of a working team environment. It didn't used to be that way, unfortunately, but things have changed a lot.
Amazing. So now that we know there is a lot beyond the eye test, let's talk a little bit about the specializing, especially from your background, which includes specializing in training pediatric eye conditions, right? And glaucoma. So what does pediatric glaucoma mean, doctor? Now maybe especially with the starting of the schools, that might help us.
Very, very good question again. Look, so I'm a general ophthalmologist. I treat adults in different conditions, such as glaucoma, such as cataract. But I do have an interest in pediatric disease, especially pediatric glaucoma. I found it very interesting when I was doing my training, so I did a bit more focused training in it in the UK. Children in general are different kettle of fish altogether. The child is not going to come to you and say, "Mom, I can't see."
True.
Or I can't see, especially, they're definitely not going to come and say, "I can't see out of my left eye."
True.
They probably won't even notice it.
Yeah.
And that is very crucial, and that's very important, because we'll talk about some conditions that are very time sensitive. And in children, in general, everything is time sensitive.
Okay.
In an adult, if probably 50% of the time, if you don't treat it now, you treat it later, you probably get the same result.
Oh, okay.
But in children, it's not the case. In pediatric glaucoma in particular, it's a different condition than what an adult would get if they get glaucoma.
Okay.
They talk about, I'll tell you an example. Children with pediatric glaucoma have the most beautiful eyes. You know why? Because they have very big eyes.
Wow.
And if you look at them, the biggest attraction in a baby is in general their eyes. So you can imagine if their eyes are even larger than what you expect.
Okay.
They look gorgeous, but unfortunately, that is the disease causing the eye to expand. It doesn't happen in adults.
Okay.
It happens in children.
Wow. And until what age, doctor?
Up to 3 years. Up to 3 years, the eye expands.
Okay.
And unfortunately, I've had cases. I remember a case who still stays with me, and she presented at 12 years of age.
Wow.
Pretty much blind, unfortunately, with high pressures, undiagnosed glaucoma. Now, we've treated her. We've done lots of surgeries for her. She's one of my favorite patients.
Lovely.
But unfortunately, the damage has been done and we can't recover it. So it is important to get regular checkups in children because of these time-sensitive issues, because of these undetected diseases, and because the treatment is, if given at the right time, is very effective.
Lovely. Good to know as parents as well. Doctor, you also treat adults with cataracts and glaucoma and many other eye conditions. From your experience, what are the most common misconceptions people have about eye health and surgery? Coming from your experience.
And coming from the community we both serve, I think it's interesting you say that, because we probably 9 out of 10. The thing, for instance, for cataracts, let's talk about cataracts.
Yeah.
The patient will come in, I'll say to them, you've got cataracts. And the first question they ask me, يا حكيم المي حسب بالعراق بيقولوا لها مي بيضاء بلبنان بيقولوا مي زرقاء بدك تعرفي اي بلد جايين لحتى تعرفي شو بتسميها وهي على فكره لا لنا مي ولا لنا بيضاء ما خاصه بالمي بس باول سؤال بيسالوا المريض استوت يا المي الزرقاء استوت يا حكيم
شو يعني استوت
استوت is it matured so there's this conception in our community. And I don't know where it came from, and it's not right.
Okay.
It's incorrect.
Okay.
That the cataract has to be mature to have the surgery. If anything, that is totally the opposite.
Okay.
Let's talk about a cataract. What is a cataract? A cataract, we all are born with natural lenses.
Yes.
In our eyes, there is a front part of the eye, there's the back part of the eye. The front part of the eye has the cornea, and then behind the pupil, which is the open black hole, is a natural lens that helps focus the light on the retina so that we can see clearly both for far away and close.
Yeah.
What happens with time, that lens starts becoming opaque, that starts developing changes in the composition of it. So it doesn't transmit the light as it should.
Okay.
That's a cataract. That's a cataract forming. The idea that the cataract needs to be fully mature, which means the lens should be fully opaque for it to have the surgery, is not necessary, because that means you are putting up with blurry vision and more advancing blurry vision for no reason. And if anything, doing the surgery on a mature cataract carries more risk.
Okay.
Because you're trying to remove a lens that has gone harder, more opaque, more dense with a machine, and we will talk about the surgery maybe in shortly. But so you're more prone to have complications. So it's opposite. You should have the cataract earlier rather than later. And the time when you have a cataract is when it starts impacting your vision. It impacts your vision for things like driving, because we have driving standards that we have to meet. Otherwise, you can't keep your license. You need your good vision to be able to walk around, because there's studies where it shows that people with poor vision are more at risk of falls.
True.
And falls in elderly is a very major issue. And also, there's if you look at the different studies, they've even showed that there's an association, not a cause, cause result association with things like dementia and psychological and mental health.
Interesting.
Because if you can't see well, how are you going to interact with your world in general?
Interesting. So the end result or the bottom line for our community, do it as early as possible. مش ضروري تستوي.
لا أبدا مش ضروري تستوي وعملوها بس تكون أسرع نظر.
100%. Once you feel you really need it, just straight away do it. Now, while we're talking about cataracts, we've seen major innovations in cataracts, right? Before it was a very manual, if you want, surgery. Now there's a lot of techniques in it, laser-based, AI-based. So what do the advances mean for the everyday patients, especially in older Australians, up to your experience?
I'll start with the laser question. So there is something called laser-assisted cataract surgery.
Right.
That came around, started becoming popular probably about 10 years now. Okay. And it hasn't taken off. Okay. It's interesting you say manual surgery. Yeah. We're still not there that yet where machines take over. We're still our best instruments are these.
Amazing.
Our hands. Cataract surgery with laser, it's been looked at and a lot of studies have been done to see if there's any advantage, and there's really no advantage. Yeah. And usually when I get asked about it by my patients, I say, I can do it for you. I can do laser assisted, and that laser doesn't take over the whole surgery, by the way. Right. Lasers does parts of the surgery itself. The cataract surgery is a multi-step surgery. Okay. And it does about 2 or 3 steps of that. The studies have not shown any advantage. Okay. But people are sort of taken with the word laser, and I offer it, but probably 9 out of 10 people don't do it. And I'll be quite frank with you. The biggest reason why they don't do it is the cost, because there's more cost involved because of the use of the laser. I think the biggest advances that are being done now in cataracts is the lens that we are placing in the eye. Nice. So maybe just taking back one step, just to explain to the listeners about cataract surgery. Go ahead. So cataract surgery involves removing this lens we spoke about, the natural lens that's not letting the light go in and focus properly on the back of the eye. Right. We have to remove it. We can't leave. That's a very typical question that I get asked by elderly Arabic community, our patients, is, are you going to put a lens in? Definitely I'll be putting a lens in. I think if we don't put a lens in, it's doing half the surgery. Okay. It's usually a complication. That's why we didn't put a lens in. Okay. So definitely the eye would need a replacement to be able to replace the deficit that you've left behind when you remove that lens. The optical deficit. أو الضعف البصري اللي صار موجود بالعين بمجرد ما شلنا مفهوم شلنا العدسة الطبيعية ما نحط محلها عدسة اصطناعية. هاي العدسة الاصطناعية هون في تقدم كتير عم بيصير بالتقنيات وبالتكنولوجيا الموجودة. The question that I get asked a lot about my patients is, when I talk to them about the different kinds or types of lenses available, I want the best for my eye. Or I want the good quality for the eye. And I tell them all the time. Maybe in different countries things are different.
They're all good quality.
In Australia, we cannot put a lens that I'm not going to say to the patient, or I'm not going to put in a, if you get this lens, you're going to get less because it costs less. Yeah. The government and the system, the way it's set up, all lenses have to be vetted. Yeah. And quality-wise, they have to be good. Patients also ask me, again, going back to our Arabic community, where does the lens made? Where was it made? Is it German? Is it English? Is it Australian? Is it Chinese? Is it Chinese? And the thing is, I say to them all the time, it's irrespective of where you have the lens made. It's when it comes here, what quality it is, has it been vetted, and that we have to have these done. I can't get a lens from overseas myself and put in a patient's eye. Right. That becomes actually a scientific study that I'm doing on this lens that's experimental as far as I'm concerned, and the patient would be having to know about it.
Doctor, while you're talking about that, do you think this is really the main barrier you might have with multicultural patients that come through your clinic? Like that they're suspicious, they have a lot of questions,
Absolutely.
they're worried. Yeah.
Absolutely. I think it's part and parcel for where we come from.
Yeah.
I think there's a lot of sort of concern, let me call it. Maybe it's a bit more than that, but that the patients are the doctor, or not the doctor, but probably the system. I think it's the system thing.
Yeah.
Unfortunately, we come from countries where the system is not for
betrays us mainly.
Exactly.
So
it's not
scared.
for us. It's how much it can take from us.
Right.
Whereas I think the system here, I truly believe our system is set to serve the people.
Yes.
So we are not here, and the system's not here to rob people or to fool them or do anything like that.
Right.
And I think you're absolutely right. And that's a struggle I face every day. That you know, you need to put trust in the system.
Wow.
You need to know that everything that's the best for you is going to be done for you.
True. I agree. Doctor, let me shift a little bit back to treating children. We spoke about the glaucoma. I'd like to speak about a condition.
And by the way, sorry to interrupt.
Go ahead.
Pediatric glaucoma is a rare condition.
It is, isn't it?
It's very rare.
Yeah.
So it's not that I see a pediatric glaucoma patient every week. No, at all. And I mainly see them in a hospital setting. I'm in the Children's Hospital at Randwick. Yeah. And most, or if not all, my pediatric glaucoma patients are treated there. Okay. I treat them there. Okay. I don't. They need a multi. They're multi disciplinary approach. There's other things that are usually happening. They need lots of surgeries. Yeah. So it's a very rare thing. But if we're going to talk about more common and important thing for our list, for your listeners,
of course.
Sorry,
all of listeners.
for our community.
Yeah.
I think it's more important to talk about vision development in children.
Right.
And that is crucial.
Okay.
And vision development is very time sensitive.
Right.
The first 7 years of a child's life is, in general, is when our visual system is developing.
Yeah.
And it is a competitive development between the two eyes.
Okay.
In that, if one eye has a deficit of whatever form, if it's an optical deficit like glasses, if it is an alignment deficit like a squint or a turn, any multiple issues can impact the vision in that eye. The brain will ignore that eye and concentrate on the other eye. And if it does that, it never develops good communication between that eye.
Right.
And that's when you end up with lazy vision, or the medical term for it is amblyopia. The crucial thing about amblyopia, it's treatable if we catch it early, fix the problem that's caused in the first place, and treat it to reverse it.
There you go.
If we don't do it by the first 7 years of life, we've missed the boat.
Amazing. I think you already answered my question. Regardless the type of disease or what it's called or how it tackles the child, my question was to you, why is early detection and intervention so important? And you did answer that amazingly.
And on that note, again, our system looks after us. Yeah. So just so that people know, or mums know, and most mums would know this, there's a program called STEPS screening program. It's a program that's been instituted by New South Wales Health. It is a vision screening program that have a very high percentage of children being screened, preschool children. It's a preschool children screening program. So they target the children around the 4.5 years of age, and they check things like vision out of each eye. If there is any significant glasses prescription that the child might need, and if the eyes are misaligned, if they have a small turn, sometimes the parents don't see the turn, but that turn could be impacting their vision.
Amazing. Doctor, do you mind me ask if you know if this program is for free or Medicare bulk billed?
Totally free, nothing to do with Medicare, actually.
Okay.
This is a separate program by New South Wales Health.
Nice.
It actually goes to all preschools, to all kindergartens, and it's a requirement for preschools and kindergarten to make sure all their children go through this. Now, we've had a great track record of screening basically every single child in New South Wales.
Amazing.
That sort of fell behind a bit because of COVID.
Yeah.
So there was some misses there, unfortunately.
Yeah.
But
everything else that happened
absolutely.
in COVID had
So the only
gaps.
reason I'm mentioning it is so that mums and dads obviously know about it, so that it's something for them to tick off. Has my child had
Before
that
we
check
start
before
school?
year?
Yeah,
for
that would be
kindergarten.
great.
Yeah,
Amazing.
and that's important because we get a lot of referrals from that, and that's where. And we have time. They usually get screened about 4.5, maybe 5.
Yeah.
And as we spoke about that first 7 years of life, so we've got 2 years to sort things out.
Yeah, amazing. That's great. We really thank you for mentioning this initiative. If I got to continue a little bit about what you do, eye surgery and long-term eye care can sometimes be daunting and scary to patients, especially the children and the elderly. So how do you approach the patients, let them know the education of what you're doing, and take their consent to understand and give the options? Like, how do you do all of this without them being overwhelmed?
It's a very important issue that we face, especially in our community again.
Right.
Especially in the elderly, actually. In the elderly, combining the lack of language with the background they come from, as we spoke about, the systems they've been brought up in, and all the preconceptions they come with, you find that you're trying to sort of detangle all that for them, and I find it challenging and rewarding at the same time, because a lot of these elderly patients, are worried, concerned, skeptical, and you have to detangle all that.
You have to do some psychology with it.
Absolutely. And I think the biggest thing for me is that بحكي عربي.
Okay, good.
أول شيء بس يفوت المريض it's amazing إنه بس تطلعي بس تقولي له مرحبا أو بس تقولي له شلونك أو هذا مثل كأنه بتحسي كتافه للمريض هيك حشطه. يعني بيرتاح بكتير. حكيم بيحكي عربي وهذا. فكتير بتساعد. هيدي بتاخد شوط كتير كبير. بس بعد بدك ترجعي تشتغلي على الاشياء اللي بدنا نحكي عنها، خصوصا انا بشوف مثلا استراليه او non-Arab speaking, and they're totally different. They're totally different.
So you think in our community we need more of the well-being accompanied
education. We are missing a lot. Unfortunately, we are missing a lot, and I think the biggest barrier is to get to this vulnerable group who are, unfortunately, most of the time isolated and insulated from the rest of the world or the rest of their community, because they live in their area, in their circle, in their clusters. They never get to sort of interact with others, or if it's a news story on TV at night, they're not going to understand it.
100%.
Which is a shame.
Unfortunately. Now, you talk a lot about this system and how grateful you are for the system we've got in Australia. I'd like to tackle maybe some eye care services in Australia that might be rural or remote, and you think there are gaps that need to be addressed. What's your point on that?
There's always, Australia being such a big country with the number of with the population that we have, we always had that. We always had this isolation, medical isolation, both from a patient's point of view and the doctor's point of view. Because doctors working in remote areas, they are isolated, not just physically, but from a professional point of view. But that's changing a lot. There's a lot of things happening in this area, given and I think COVID just accelerated all this. Because we were forced to find solutions. Before,
remotely.
Absolutely. Well, it wasn't remotely before. It was before we were getting sort of isolated in our own cities. So we had to find ways of dealing with this, and that's sort of come along. We for instance, going back to children, they started doing a lot of work on parents assessing the children's eyes at home, remotely with apps. it still has some way to come.
Yeah.
It hasn't sort of fully matured, but that's accelerated things. In addition, of course, the topic of the moment, AI. I mean, AI. Some people can look at it as the enemy, and some people can look at it as a great tool. And I think it's a great tool.
Okay.
I think it's a great tool. I think it should work to complement our as a doctor, I want to help as many people as possible, see as many cases as possible, and deal with the interesting stuff.
Yes.
At the end of the day, I've done medicine for a reason.
Yes.
I find it interesting. And the interesting part comes from the interesting cases that they're going to make you think.
Scratch your brains.
Get the grey matter going again.
Yeah.
And I think AI will help sort of deal with the more common, more straightforward cases, help the doctor deal with them so that they can concentrate on more advanced cases. So I think watch the space. That's all I'd say. I think there's a lot to come.
So you are telling me from that from the advances that we've been seeing in eye care industry, that your most exciting technology that you like is the AI assistance.
AI, yes, absolutely.
Have you used it in your practice?
Oh, yes. We get for something as simple as AI scribes.
Yes.
That's the biggest thing in medicine now.
Okay.
And there's a lot of companies. The different aspects. For instance, being a pediatric subspecialty doctor, there's a lot of work being done on screening premature babies who have potential problems with their retina.
Wow.
And now we are doing where the nursing staff will take the images. Instead of me going and having to examine the baby myself, they can take pictures and I can review the pictures on a laptop. Same thing happening with diabetes and the eyes. The eyes get affected a lot, and I see a lot of them in our community. Unfortunately, there's another issue of bugbear that diabetes is so misunderstood.
Okay.
So misunderstood.
Yeah.
And the repercussions of it so immense.
Wow.
But we can, instead of having to look at the patient, there's a lot of work being done where AI is assessing fundus or retinal pictures to look for problems like that. There's a lot of things. But going back to AI scribe, now I can have a speaker on my desk, have it on. And by the way, it does Arabic. It does all languages.
It does all languages.
So
amazing.
it's not that because the patient, and I'm speaking Arabic with the patient.
No, it can automatically switch with you.
It picks it up.
Yeah.
And so it records all the conversation, it summarizes it for you, it takes a lot out of the consultation time where you're sitting there typing and doing all this. You have a record of it, you can go back to it.
Wow.
That's a simple example that is helping so much.
Helping. That is amazing. You did say a while ago, watch this space after AI. If you could envision in the future of eye health in Australia in 10 years' time, what would it look like in your opinion? And would the ideal eye care access be there?
I think in 10 years, usually 10 years is not a long time in medicine.
Yes.
Given the way things move.
Okay.
But I think this time it might be different. I think in 10 years, we're going to see a lot of change. What sort of change? Where do I envisage things? I guess, patients being able to, send the doctor all the information from home. That's a possibility, depending on the specialty, depending on maybe in eyes that might not be there yet. But what I think the biggest help is going to be in the clinic, where the patient's streamlined assessment, by the time they come to see the doctor, I might not even have to examine the patient. That's how simple how big it is. I can look at the screen with the various modalities that we have, with the various assessments that my assistants have done.
With a no-touch kind of...
Like I look at the screen, one screen will show me the back of the eye, one screen will show me the front of the eye. Everything's been assessed to a very minute detail.
Amazing.
And all I'll be doing is consulting the patient and giving an opinion then. I think that's not far away. We sort of are doing it.
Do you think you would still be there, or would a robot be replacing you?
Very, very, very interesting. I'll tell you a story.
Yes.
A friend of mine who is a specialist in the States, he did a presentation to the college meeting in the States, a massive college meeting.
Right.
and he was asked to look at AI versus humans, or computers versus
Okay.
humans. And he looked at 4 or 5 different categories. So he looked at things like accuracy,
Right.
repeatability, knowledge, and everything. And not going through to a lot of details, he came up with this statement at the end. He said, when we teach the computer how to cry,
Wow.
is when we lose our work, our jobs.
Wow.
So I think, there's
The
a lot.
humane part of it would
Yeah.
not happen. That is interesting.
Yes.
Doctor, believe it or not, we're coming towards the end of this show, and the very last session I'd like to do is some myth busting.
Okay.
So I have some.
I think we did a bit of that.
We did.
But we can do some more.
Do I make it quick?
Yes.
I'll give you some statements about eye health. You just tell me if they're true or false with a very little bit of why. Are you ready?
Let's go.
Let's go. If my vision seems fine, I don't need eye checks until I'm older.
Not entirely true, because there's things like glaucoma we spoke about.
Yes.
We didn't ever mention this. Glaucoma is known as the silent thief of vision.
Yes.
Or سارق النظر الصامت.
Yeah.
So you could have glaucoma and it's causing damage and you wouldn't know.
Right.
So for that reason, for glaucoma, for instance, we recommend regular eye checks after the age of 40 if there's no risk factors. If there's risk factors, that changes. That's why it's important to see your local optometrist on a regular
Right.
basis. Not just if you need glasses or not. You can't just say, I don't need glasses, I don't need to see the optometrist. The optometrist's role is much bigger
More
than that.
than eye
And
glasses.
they test the pressure of the eye, they look at the back of the eye, they make sure the nerve is fine. So it's not entirely true, no.
Amazing. My second statement, glaucoma always causes pain or obvious symptoms before you lose vision.
I think we already answered that.
Yes,
It's
silent
a silent thief
Yeah.
of vision. Actually, rarely, there are cases where glaucoma
Yeah.
causes pain. They are not common at all. It's actually more like an emergency situation where
Right.
they end up to needing emergency surgery, emergency laser at least,
Right.
and possibly surgery. So absolutely not true. The glaucoma can do a lot of damage without knowing anything about it. It's
Wow.
like blood pressure.
Right.
Not everyone with high blood pressure will have headaches.
True.
But they'll be causing a lot of damage.
Interesting. Cataract surgery is risky and should be avoided unless vision is very bad.
We already answered that.
Yes.
Actually, on that matter, it's probably, if I'm not going to say the most successful, but it would be one of the highest rates of success. The success rate of cataract surgery is over 95%.
Nice.
And that's me being very conservative.
You're right.
It's a very common procedure. It's a highly successful procedure. There's no risk. This is the first thing I tell the patient. There is no surgery without risk. The first thing that the patient will ask me,
Yeah.
مضمون يا حكيم؟ ما في شيء مضمون بالجراحة.
البانادول فيها ليفلت
100%
بلو.
ما في شيء مضمون، بس
Yeah.
إذا بتسأليني بشكل عام الريسكس فيها، عندك ريسك أكتر يصير معك شيء لا سمح الله أنت عم تقطع الطريق من ما يكون بالكاتاراكت
And
سيرجري.
especially in our community بيجربوا يأجلوا العملية قد ما فيهم.
ما بس بترجع لنفس القصة إنه
Yeah.
إذا أجلنا العملية عم بتزيد الكاتاراكت،
Yeah.
صارت العملية معقدة أكتر.
True.
يعني بالعكس صحيح.
True. Okay. Children outgrow squints on their own. There's no need for early surgery.
Partially true in that some kids can get better at controlling their squint.
Okay.
It doesn't go away. It's controlling. It's a particular kind of squint. But to be on the safe side, you should not take that as a statement, because it's not early surgery, it's not late surgery, it's correct time of surgery.
Right.
And every squint the squint is a very massive umbrella term. There's so many different kinds, there's different causes.
Yeah.
So the least you have to do, if you notice a squint in a child, they should be assessed. The least they can do is have them assessed, make sure that, because it could be that the squint's not bothering you, but it could be causing lazy vision.
Yes.
And this is what we spoke about. That's more important.
Right.
Correct treatment at the right time is the
Amazing.
important thing.
Our last one, once you have glasses or contacts, there's no point in seeing an ophthalmologist.
It's not a myth, actually. Not every person who wears glasses or contact lenses needs to see an ophthalmologist. I think
Okay.
in our country,
Yes.
in our medical and health system, optometrists play a big role there.
Yeah.
Optometrists are very good at referring on to an ophthalmologist to if the patient needs it. So they don't necessarily need to see every person who wears glasses or contact lenses, but if there are any concerns and they've been recommended to, they should do that.
But my point maybe there would be, is it reversible? Do I have to go to the ophthalmologist? I can do a surgery and I can take my glasses off?
Good question. Look, actually one other myth on that, on the same topic is, I don't want to wear my glasses because my eyes get worse with glasses.
Okay.
That is very untrue.
Okay.
What you get used to is nice clear vision. So what happens is you'll be walking around not knowing that you got short-sightedness. Okay, you're walking around, you think that's what the world looks like. The optometrist gives you a pair of glasses, you put them on, wow.
New world.
And then you take them off, and then there's a sudden comparison of what clear vision is and what blurry vision is, and you think, oh look, these glasses ruined my vision. It never used to be like this, but it was.
Right.
It's just you didn't know.
Right.
So this is one myth that that is totally untrue. That glasses do not ruin your vision or your eyes.
Okay.
The other part of it is that if you want to do something to get rid of glasses, that's definitely an option. Like it's called refractive surgery, and that can come. It's not just laser, by the way.
Okay.
There's many options in that category.
Okay.
That is just a replacement for glasses. That you don't have to have it. You don't, if someone, and actually on that matter, it's considered by the health system cosmetic.
Oh, okay.
So surgery to get rid of glasses, you're not covered by Medicare. Medicare doesn't have an item for it.
شو glasses.
ها؟
شو glasses. Specsavers على قليلة. Medicare covered.
تعرفي في كثير بيجوا عندي بيكون بدهم يلبسوا عوانات بدون أي درجات.
بس
لأنه
they like the style.
العوانات.
Oh, nice. I like it. Amazing. Dr. Elias, believe it or not, we have come to our end.
Quick.
I know. I enjoyed that
Time
so
flies
much.
when you're having fun.
I know, it is. I really need to thank you for shedding the light on such an important topic and telling the people about, their eyes, their eye health. So thank you so much for joining us today. I really appreciate it.
Thank you for having me. It has been a great pleasure.
Amazing.
And I'm going to apologize to you and the listeners if I spoke too much. I'm very passionate about this.
No, not at all. We enjoyed it. The topic is interesting, so thank you once again.
My pleasure. Thank you for having me.
Awesome. To our listeners, before we end our discussion today, if you haven't had an eye exam recently, especially if you are over 40, have a family history of eye disease, or have children, please consider booking a checkup. Eyes are one of the few parts of our body where early intervention can make a dramatic, lifelong difference. This was Scientifically Speaking with Christine on Oz Arab Media. Until next time. Thank you.